Hello, Wenjing. How are you? Thank you for joining. Do you hear us okay? And can we test your audio, please?
Yes, I can hear you. Can you hear me well?
I can. Thank you so much. And can you please leave your camera on for us from this point? Thank you so much.
Sure.
Hello and welcome to today's press conference, the first in the new year. It's the virtual press conference on global health issues. It's Tuesday, 13th of January, and we are here in the WHO headquarters in our new press conference room, so we're very happy to launch that officially, this time online, with you. We have a couple of special topics today. It's the new reports on taxes on sugary drinks and alcoholic beverages that will be launched today in a webinar right after this briefing. By the way, the embargo for these reports have been set for 2 o'clock Central European Time, 1400 hours. That's in about 20 minutes, 15 minutes. And we also will discuss an update on the cervical cancer prevention and control. We'll have two specialists on this one here today with us, and I'll introduce them in a short moment. But first to the podium. Of course, we have with us today the Director General, Dr. Tedros Adhanom Ghebreyesus. We have the Chief Scientist, Dr. Sylvie Briand. We have Dr. Jeremy Farrar, Assistant Director General for Health Promotion and Disease Prevention and Care. We have Dr. Etienne Krug, Director of the Department of Health Determinants, Promotion and Prevention. We also have Dr. Chikwe Ikweazu, the Executive Director for Health Emergencies Program. And we have with us Dr. Catherine O'Brien, Director for Immunization, Vaccines and Biologicals. These are the people here on the podium. We also have a couple of experts with us online or here in the room, but two to mention specifically. We have for the topic of the new reports on taxes on sugary drinks and alcoholic beverages, we have Dr. Anne-Marie Perucic. She's health economist and the lead author on that report. And we have on the cervical cancer topic, Dr. Prebo Barango. He's cross-cutting specialist on NCDs and special initiatives. With this, from my side, welcome. By the way, if you want to get into the queue for the questions, please raise your hand with the raise your hand icons, and then we'll get to you later, and you will have to unmute yourself at that point. With this, over to you, Dr. Tedros.
Thank you, Christian. Good morning, good afternoon, and good evening. And Happy New Year and welcome to WHO's first media briefing for 2026. Last Friday marked 1,000 days of Sudan's civil war. Almost 3 years of continuous violence have turned Sudan into the worst humanitarian crisis globally. An estimated 33.7 million people will need humanitarian aid this year, and 13.6 million people are displaced, making Sudan the largest displacement crisis in the world. Poor living conditions, overcrowding, lack of access to safer water, sanitation and hygiene, and a breakdown of routine immunization are fueling disease outbreaks. WHO is supporting the response to outbreaks of cholera, dengue, malaria, and measles. But just when the people of Sudan need it most, the health system has been severely damaged through attacks on healthcare, lack of essential medical supplies, and shortage of health workers and funding. Despite sustained efforts by WHO and partners to restore and revive health services, more than 1/3 of health facilities remain non-functional. WHO calls for unrestricted and safe access to all areas of Sudan to restore access to health services, and we call for the protection of civilians from attacks, including health and humanitarian workers and patients. And we call for an end to the conflict by all parties in Sudan. As always, the best medicine is peace. Now to our main news of the day. As you know, over the past year, sudden and severe cuts to aid have caused severe disruptions to health systems and services in many countries. WHO is supporting countries to maintain essential health services in the short term while mobilizing domestic resources to make the long-term transition from aid dependency to sustainable self-reliance. One of the best tools for doing that is health taxes on tobacco, alcohol, and sugary drinks. Health taxes have been shown to reduce consumption of these harmful products, helping to prevent disease and reduce the burden on health systems. At the same time, they generate an income stream that governments can use to invest in health, education, and social protection. Last year, WHO launched the Street by 35 initiative, which aims to support all countries to use health taxes to increase the real prices of tobacco, alcohol, and sugary drinks by 2035. However, health taxes are not a matter of set it and forget it. To be effective, they must be designed carefully and adjusted regularly. Since 2008, WHO has published regular data on tobacco taxation in our biennial report on the global tobacco epidemic. Today, we are publishing new reports on taxes on alcohol and sugary drinks. They show that in most countries, these taxes are too low to be effective, poorly designed, not adjusted regularly, and rarely aligned with public health objectives. As a result, alcohol and sugary drinks have become more affordable, even as the diseases and injuries associated with their consumption continue to place growing strain on health systems, families, and budgets. Health taxes are not a silver bullet, and they're not simple. They can be politically unpopular, and they attract opposition from powerful industries with deep pockets and a lot to lose. But many countries have shown that when they're done right, they're a powerful tool for health. For example, in the Philippines, a major tax reform on tobacco and alcohol in 2013 increased revenues by more than 5 times, which supported the expansion of national health insurance to more than 15 million poor families. In Lithuania, a major tax increase on alcohol in 2017 was associated with an almost 5% reduction in all-cause mortality the following year. In the United Kingdom, a tax on sugary drinks introduced in 2018 reduced sugar consumption, generated £338 million in revenue in 2024 alone, and has been associated with lower obesity rates in girls aged 10 and 11, especially in the most deprived areas. Many more countries are following the example these countries are setting. Last year alone, Malaysia, Mauritius, Slovakia, Sri Lanka, and Vietnam were among countries that introduced or increased taxes on tobacco, alcohol, or sugary drinks, or all three. And already this year, India introduced a new excise duty on tobacco, and Saudi Arabia introduced a tiered excise tax on sugary drinks with higher taxes for higher sugar content. WHO looks forward to supporting more countries to design and implement health taxes to protect health and to transition away from aid dependency toward sustainable self-reliance. Finally, this month marks World Cervical Cancer Awareness Month. Cervical cancer is one of the most preventable cancers, yet it still takes the lives of many women, mostly in low and middle-income countries. We have the tools to make cervical cancer the first cancer to be eliminated. Vaccines to prevent it, tests to detect it, and therapeutics to treat it. That's why in 2018, I issued a global call for action to eliminate cervical cancer, which was followed in 2020 by a global strategy with the 90-70-90 targets. 90% of girls vaccinated, 70% of women screened, and 90% of women with cervical cancer or precancerous lesions treated, all by 2030. Since then, Nearly 60 countries have introduced HPV vaccination, and 162 countries now include the vaccine as part of their national immunization schedules. 65% of girls globally now live in a country where HPV is in the vaccine schedule. That proportion is expected to rise to more than 80% in the coming months as more countries include HPV in their schedules, including India. Many countries at all income levels are showing that by integrating vaccination, screening and treatment, elimination is within reach. Late last year, Australia announced it had no cases of cervical cancer diagnosed in women under 25 in 2021. Several countries in Europe are close behind. Rwanda set itself the goal of achieving the 90-70-90 targets by 2027, 3 years of schedule, and already has vaccinated 77% of girls, screened 31% of women, and treated 81% of women with cervical cancer or precancerous lesions. From Bhutan to Brazil, Chile to China, Pakistan to Papua New Guinea, Sierra Leone to St. Vincent and the Grenadines, and Timor-Leste to Tanzania, dozens of countries are expanding vaccination, screening, and treatment. They're showing that eliminating cervical cancer is not a pipe dream. It's achievable. Christian, back to you.
Thank you very much, Dr. Tedros. And with this, we open the floor. And as I said, please raise your hand with the raise your hand icon and unmute yourself when it's your turn. And we'll start with Robin Millar from AFP. Robin, please go ahead.
Thank you.
Here you go.
It's a question. Thank you. It's a question on sugary drinks. When consumers are making their choices, they're often looking at one version of a soda with sugar and another version of it with sweeteners. So are sweeteners clearly the better choice, or do they come with their own risks that consumers need to bear in mind? And secondly, is there an issue as well with labeling? If a drink has sugar as its second biggest ingredient after water, should it be clearly labeled on the front as a sugar water drink? Thank you.
I think we want to start with Dr. Luz Maria de Regil, if we have her online, Director for Nutrition and Food Safety. Luz, are you there?
Yes, I am here. In many countries already, there is front of the package labeling, and many countries, particularly in Latin America, but also in other regions, have policies to mark at the front of the pack label whether the foods are high in sugar, and that allows users to have more information, more clear information on whether the amounts are beyond what is recommended for that particular food. I think that the report already covers other pieces on sugars, and I will pass it to my colleague, Etienne.
Just looking if anyone wants to add anything here. Not in particular. Thank you very much. Then we move on to the next question. Jeremy Lange from RFI. Jeremy, please go ahead and unmute. Jeremy? If we can't reach Jeremy or something wrong with the unmute button, then we'll try with Kerry Cullinan.
Can you hear me or not?
Oh, now we go. Okay, back to Jeremy. Jeremy, RFE, please. We had you there for a second.
And now? Now is it better?
Now it's good. Please go ahead.
Now it's good. Thank you. The question is not related to the report. Sorry about that. But as you well know, next week, I think on the 20th, it will be 1 year since the US withdrew from the WHO, and it will be official next week, if I'm not mistaken. I would like to know, 1 year later, where does WHO stand? Did you manage to cope with the financial issue? Just random question, like how do you feel 1 year later, basically?
How do we feel 1 year later? I'm giving to Steve Solomon, our principal legal officer.
Can you hear me well? Great, thank you. Thank you for the question. We're getting asked this question in many different forms, including the one you just asked. And it really goes to the issue of when exactly will US withdrawal from WHO be effective? And let me say, this is a very important question. And there may be differences of view among member states on the answer to this question. And let me explain why that's the case. The reason there may be differences of view on this issue is simple. It starts with the WHO Constitution. The WHO Constitution is a treaty, the treaty that establishes WHO. It's contained in this book. We call it the Green Book. It's available on our website. And very notably, the WHO Constitution does not have a withdrawal clause. This was not an oversight. It was very deliberate. In 1946, the drafters understood the historic struggles against the international spread of disease, and they saw how a truly universal organization would make the world safer. So they did not include a withdrawals clause. Instead, they provided flexibilities within the treaty so it could accommodate all countries. And by the way, they were following the example in not including a withdrawal clause. They were following an example of the UN Charter, which also does not include a withdrawal clause, and also was based on the principle of the importance of universality for that instrument. So there is no withdrawal clause in the WHO Constitution. And in 1948, the US made an arrangement, an agreement with the World Health Assembly, reserving for itself, alone among countries, the right to withdraw on two conditions. One, 1 year notice, which you've mentioned, and the other condition was that the US will meet its financial obligations to the organization in full for the current fiscal year. So there is also, therefore, an issue of how member states, the other countries of the organization, will look at this condition. And there will be a discussion among member states about this. We expect this discussion to come up at the WHO Executive Board, which will be next month. That discussion, we expect, will continue at the World Health Assembly, which will be in May of this year. We look forward to member states discussing this. And why member states? Because this involves, and these questions of withdrawal, the questions of the condition and the promise and the agreement reached between the US and the World Health Assembly, these are issues that are reserved for member states. They're not issues that WHO staff can decide. So during the governance meetings of WHO, these will be discussed. In other words, while there is an open question on when and how withdrawal happens, there is, it's important to say, not an open question about what the Constitution says about WHO's overall mission. The Constitution sets out the objective for the organization of the health of all people wherever they live and without discrimination. And those are the principles of WHO. Those are the principles that were set out in 1948. They will continue to apply. They apply today, and they will continue to apply as long as there is a WHO. Thank you.
Thank you very much, Steve Solomon, and I'll hand over to the DG, Dr. Tedros, please.
Yeah, thank you. So I don't know if you can answer how do you feel, but maybe if you ask me my wish instead of my feeling, I hope the US will reconsider its decision and rejoin WHO. That's what I wish. The reason I'm saying this is withdrawal from WHO is a lose for the United States, and it's also a lose for the rest of the world. I also believe that when I say lose-lose, it also makes the US unsafe, the withdrawal, and makes the rest of the world unsafe. So it's not really the right decision. I want to say it bluntly, because I believe that there are many things that are done through WHO that benefits the US, and only the WHO does, and especially the health security issues. That's why I said the US cannot be safe without working with WHO. And there are many examples actually to say that. So my wish is, I hope they will reconsider and continue with the other member states working with WHO. And then on the funding level, of course, as you may remember, I have submitted a revised budget to the governance, and the governance has approved the revised one, which is a very reasonable one. And based on that budget, we did the restructuring, and the restructuring that we call Future Fit WHO. And we have done the Future Fit restructuring based on WHO's core mandate. All the prioritizations has been done based on that. Of course, the process has been completed. As you may remember, we started from the top leadership. The senior management is reduced by half, the middle management department reduced by half, and then that goes all down to the expert level, and we have made all the adjustments based on the prioritization process we have set for ourselves. And we have also observed 3 principles of transparency, fairness, and humanity. And we implemented the process based on these 3 principles. And then when it comes to funding, we have proposed a reduced budget, as I said earlier, and all the prioritization helped us now to fit into the new budget. So now we believe that we are okay with the funding level. Actually, as we speak, for the 25-26, for the 26-27 biennium, we have about 75% of the budget we need. But the 25% is left to be raised. Of course, raising the 25% remaining could be tough because of the environment. But the 75% we secured actually more than any time in the past in terms of the level of funding that we have secured at this level at the start of the budget year for 26-27. So I can say it has stabilized already. We were prudent the last few years, and we have been saving, and we actually paid salary gaps and the indemnities from our own savings. So the cash flow and so on is stabilized. I want to assure you that. Then when I say for US to reconsider its return, it's not about money. It's not about money. Money can be adjusted. It's about cooperation. It's about solidarity. The best immunity is solidarity. It's in the interest of the US. It's in the interest of the rest of the world. So it's not about money. And I don't want it to be seen as such. I'm not saying money doesn't matter, but what matters most is solidarity, cooperation, and for the whole world to prepare itself for any eventualities to a common enemy like a virus, like COVID that we have seen. So we need cooperation and solidarity for that. Then the other confidence that comes from in terms of finance is because of the finance reform we started in 2017-18 as part of our transformation. As you may remember, we asked our member states to increase their assess contribution or the core budget to 50%. They agreed to do that in 2022, and they have already approved the 2 installments in May 2023 and May 2025. That has actually increased the core budget, and it helped us also to save many jobs. For instance, of course, we have separated some colleagues, the figures, but at the same time, because of the increase in assess contribution or membership fee, we saved about 600 to 700 jobs. So that helped us to minimize the impact. And for the future, I think we have 3 more installments in 2027, 2029, and May 2031 that we expect from our member states. With that, hoping that it will happen, the organization could be more stable and prevent shocks like now, because by 2031, but minimum, the core budget will be 50% as already planned agreed in 2022. But we're looking for additional resources, and if we can increase the flexible funding, which we can, to 80%, that will help even the organization to be more stable. And that's why we're saying future fit WHO with stable funding, but at the same time focusing on its core mandate based on the prioritization, focusing on laser focused on the core mandate, and helping countries based on their priorities and fit for the health conditions in the future. But the funding is very important for our organization, for WHO, to really deliver. And that's why, side by side with the technical changes we are making, we're also addressing the financing issue. So that's what I would like to say, but it's not just the funding, it's part of the overall restructuring we're doing the future fit WHO. Thank you. Christian?
Thanks so much, Dr. Tedros. Now we go to the next question, but before we do that, I understand we do have a bit of an issue with the audio, so always bear with us in case it takes a second or two longer to get you connected. And secondly, it looks like a couple of you have not identified themselves clearly on the net. So in case you want to ask a question, please identify yourself with the name and agency properly. Otherwise, we cannot take you. Next question, as we said before, is now to Kerry Cullinan from HPW. Kerry, please go ahead. And let's see, do we get you?
Okay.
Here we go.
Great. Thank you, Christian. My question is about the taxes again. The report notes that the taxes are too low, particularly for sugary beverages, where the average is 2%. So what would be an effective level for taxation? And also the DG mentioned that there are powerful industries with deep pockets that are opposing these. And some are using the tactics that we've seen from the tobacco industry. So how can countries, especially small countries that don't have strong economies, address these powerful industries? Thank you.
Good question. Thank you very much. And we go to Dr. Jeremy Farrar, Assistant Director General. No? You want to go first? Go to Anne-Marie Perucic? Okay, let's go there.
Thank you. Regarding the technical question on the low level, so 2% is median, so it's somewhere in the middle, but on average it's around 9%, the tax on sugar sweetened beverages. And that's very low because if we compare, for example, with tobacco products, on average it's about 50–60%. So you can see the difference. And we know that taxes increase prices, so if you increase your tax, prices go up, and this reduces consumption. So the proportion is an indicator of how you can affect prices. When it comes to dealing with the powerful interests, I think governments, we have many examples of governments that have really done very well on taxes. So there was a mention, for example, of Mauritius. They recently doubled their tax on sugar-sweetened beverages. So it's possible for all countries to increase taxes despite pressure, because the evidence is there. We know that taxes do reduce consumption, they generate revenues, and they're good for public health. So the argument of public health, improving public health, should be always be prominent and a good response to pressure from private interests. Thank you.
Anything to add? Yes, please.
Thanks, Christian. Thanks, Gary, for the question, and Anne-Marie, who led the report. Just to put into a little bit more context, though, this report that's being released, the timetable is today and tomorrow, but it does build off work in July 2025 on tobacco taxes as well. And I think we need to see these three together, in a sense. The evidence from tobacco is obviously extremely strong, that if taxation is increased, consumption reduces. And we can anticipate from the existing evidence that this will be true for alcohol and sugary drinks as well. But this isn't just about taxation as a negative. This is also about using taxation as a move to shift behavior, generate health promotion and prevention in all health systems that are struggling to deal with the rise of non-communicable diseases and others. And it also allows countries to raise revenue which can then be reinvested in whatever the country chooses, from health to education to any other aspects of what the country wants to use its fiscal policies for. So it is about taxation, it is about changing behavior, it is about reducing harmful products in the marketplace, but it is also about investing in health and other social measures. So it's a win-win on every aspect.
Thank you so much, both. And we want to try now with Michael Guarisa. He's from the Health Times in Zimbabwe. Michael, if you can, please unmute it.
Oh, thank you, Christian. My question is on taxation as well. So I come from Zimbabwe, where the government has introduced a tax on sugary drinks that is called the sugar tax. But there have been concerns that these taxes are placing an unfair burden on low-income families. So I just want to find out from the DG, do you believe these taxes are equally appropriate for low and middle-income countries facing poverty and food insecurity? And how best do you think these taxes should be crafted without putting a burden on the poorest of the society? Thank you.
Thank you very much, Michael. And we go to Dr. Etienne Krug. He's Director for Department of Health Determinants Promotion and Prevention.
Yeah, thanks so much. The word tax sometimes has a negative connotation, and therefore you use the word burden, but really it's not. As Jeremy just said, this is a preventive measure. We know that alcohol is an unhealthy product. We know that tobacco is an unhealthy product. We know that sugar consumption is unhealthy. All of these issues lead to cancer, cardiovascular diseases, injuries, etc. And so even the most poorest family, when they're hit by a severe injury, by a cancer or a cardiovascular disease, it throws them into further poverty. So they shouldn't be seen as a burden. They should be seen as a prevention measure that helps avoid consumption of unhealthy products. So yes, these taxes are relevant even for the poorest countries because it's about prevention.
Thank you, Etienne. And maybe Anne-Marie, you want to add something?
Yes, I'd like to add also that lower income groups are more price sensitive. So when something gets more expensive, they reduce their consumption to a greater extent than higher income groups. And we've seen it specifically on tobacco and even more recently in the experience of Mexico or the UK. When they introduced their tax on sugar-sweetened beverages, they followed closely their populations to see how that would impact on consumption. And the greatest reductions in consumption were among the lower income groups. So in terms of also health gains, the health gains will be greater also among lower income groups because of their reaction to the price and tax increases. Thank you.
Thank you very much, both again. Let's now try with Maya Plans from the UN brief. Maya, if you can, please unmute. Go ahead.
Thank you very much for taking my question. My question is related to the cuts, that budgetary cuts, and the number of people who have been laid off by who in the last year, given the situation with the funding withdrawal from the WHO by the United States. How many people have been laid off? Do you have a number?
I think we didn't quite understand, but maybe Patrick, do you have an answer about how many people? Yeah, I must admit I haven't heard the full part. Do we need to repeat? Yeah. Maya, please repeat.
Yeah, how many people have been laid off by WHO given the funding circumstances?
Yeah, that's the short version. How many have been laid off, or the combination of laid off and retirement? Patrick?
Thank you for the question. Our reports to the Executive Board and the PBAC will set out these numbers in detail. But broadly, I can say that by 30 June 2026, mid-year, the number of WHO global staff will be projected to reach 7,360, which represents a 22% reduction compared to 1 January 2025, which was 9,401. It should also be noted that approximately 1,052 additional vacant positions are included in that number. So depending on how those positions are filled, that number could be adjusted. Thank you.
Thank you very much, Patrick. And just so before we go to the DG, just to say this was Patrick Cronin, Coordinator for WHO Human Resources and Talent. And Dr. Tedros.
Yeah, no, I just wanted to add to that. The 22% has actually two parts. So the question is the people we laid off. So it's almost around half of it, because half of the 22% was done through natural attrition. For instance, by abolishing positions from which our WHO colleagues have retired. So not hiring in these positions that are opening. That really helped. And then the other solution was we offered voluntary early retirement to staff, and many have used the opportunity, especially those who are 55 years and above. And that also helped. So through that, we managed around 1,080, I think, if I'm not wrong, positions actually through natural attrition. So the separations global is around 1,200 something. So need to see that. I think that's how you can get the full picture. But then the separations could have been higher. And I said it earlier when I answered, the question about our funding level. The assessed contribution, the decision by our member states in 2022 to increase their membership fee has helped us to save 600 to 700 jobs. That could have been added to the separation if we didn't have the finance reform. So it's not like a simple answer to the question. I just wanted to give you the full picture in addition to what Patrick said. Thank you.
Thank you, DG. Now we go again to the African country. We have Savi News Africa, and that's Princess Ekwe Ajide, if I get your name right. Please go ahead and unmute.
Yeah, you got it perfectly, as if you're an African.
What?
Yeah. Thank you for the opportunity. My question is, coming from a region where manufacturers may have the tendency of lying, they could tell lies about the labeling. So I want to ask, is there a measure to ensure that manufacturers could tell lies about what is contained in their product as sanctioned? Do you have measures like that so that when we look at the labeling, we are sure what's written is what's contained? Thank you.
I'm not quite sure. Maybe we want to go to Dr. Luz Maria de Rigil, Director for Nutrition and Food Safety for that one. Let's try Luz.
Yeah, no, I mean, in all these food policies where we are recommending to change the levels of sugar, sodium, or unhealthy fats, we also encourage that these policies and regulations are not only developed by the nutrition department, but also food safety, because food safety are the ones that are in charge of monitoring the food supply and inspection, and also for the enforcement. And it's very important that the regulations and policies have provisions for the enforcement of this. So if they have the tendency, if there is any tendency to lie on the labels, the important part is to establish a monitoring system, food monitoring systems within the food control system, and ensuring that the governments have the capacity to enforce for further compliance. And I would say that in some cases, when governments have limited capacity, the civil society has made an intentional effort to monitor the amounts of sugars in this case, or unhealthy nutrients and unhealthy amounts of nutrients in certain foods. And they are strong advocates of compliance, but also to help governments to make the case and invest more on monitoring and enforcement. Over to you.
Thank you very much, Luz, and Jeremy Farrar, please.
Yeah, just to say on this one, to add to what Luz just said there, this is not just something the World Health Organization works on its own. We work incredibly closely with the other UN agencies that look after the food supply system, the agriculture system, FAO in Rome, and WOHA in Paris, and United Nations Environment Programme. So working together as part of that quadripartite, along with then the World Trade Organization and others, allows us to have a unified, consistent voice that speaks to areas that are directly under health, like regulation around pharmaceutical products, but also sometimes not directly in the health field, but are in associated fields, like, for instance, the food and agricultural sector. Working together through those multilateral agencies makes a huge difference.
Thank you very much, both, for this. Next question goes to Laurent Sierro from Swiss News. Laurent, please go ahead and mute.
Yeah, thanks, Christian. And first of all, I'm here to all of you. Good to see you all. I'd like to follow up after Steve Solomon's response to Jeremy's question on the legal approach to the U.S. withdrawal. So when you mentioned the second condition, the need for the U.S. to have met its obligations, its financial obligations in full for the fiscal year, is it the case? Can we say that this condition has been fulfilled by the US? And then you mentioned that discussion to come between the other member states, first at EB and then at WHA. Does that mean that the US will consider themselves as out of the organization as soon as end of January? But does that mean that there will be a kind of formal decision of acknowledgement by the other member states in a form of formal consensus decision, or even a vote if one member state asks for a vote? Thank you.
Thank you, Laurent. And yes, to Steve Solomon.
Yes, and thank you for the question. So to the first question, has the condition been fulfilled? This is exactly a question that is an open one, and member states will be considering that question again at the EB next month, and perhaps at the Health Assembly. The current situation is that the U.S. for 2024 and 2025 is in arrears on its payments. You can find the full description of those amounts, as well as every other country's amounts, on the WHO website. There's a very transparent handling of all those financial figures available on our website, and that has been the case for many years. And then your second question, will the U.S. consider themselves out? That is a question best addressed to the U.S. So thank you for both of those questions.
Yeah, thank you very much, Laurent and Steve. We have two more questions on the line. Now I have Be Well Media, and that's Jessica Stewart. Jessica, please go ahead.
Hello, how is everyone? Thank you for taking my question. I have a few questions on the pricing. I saw in the reports that it is reporting that water is also being highly taxed as well. In I'm not sure how many counties or countries, but I was curious, are there any talks about lowering the price of water compared to sugary prices? And an example would be, I'm in the US in Des Moines, Iowa. Water at the convenience store is $2.69 a bottle or 2 for $5, or you can get vitamin water, which we know is sugary water, for 3 for $5, and then you can get a smoothie for $4.99. And how, with these incentives, are we going to actualize healthy decisions like drinking water? I guess anyone have any thoughts on that?
Yeah, we'll go with Anne-Marie Porucic on the pricing and the taxes.
Thank you. So what the report shows is that among the countries that do tax sugar-sweetened beverages or non-alcoholic beverages, to be broader, half of them tax water. So what we highlight is that water should not be taxed because it's a healthy alternative. But maybe what should be more encouraged is buying or drinking potable water or clean water. It doesn't have to be necessarily bottled water. We don't have information specifically on the price levels of water, but we assume that we also presume that since there is a tax applied on these beverages, they will be more expensive than they should be. And the recommendation, of course, is to remove the tax. Thank you.
Thank you very much, Jessica and Anne-Marie. Last question goes to Catherine from Vital Signs News. Catherine, please go ahead and unmute.
Hello, Catherine Fiore, Vital Signs. My question is about the European Commission launched its cardiovascular plan, disease plan, Europe's Safe Hearts plan, and in it there was a proposal, a vague commitment towards a levy for highly processed foods and highly processed foods and sugary drinks. But in a previous draft, there had been stronger proposals for new taxes on highly processed foods and alcopops. And I'm just wondering, in their deliberations, did the EU contact the WHO for their advice? Did you give any feedback to them? And will you be working with them on this in the future? I know that you have a close working relationship with the European Commission on a number of issues. So that's my first question. And my second question is a general one about vaccine recommendations. The US announced changes to its plans, its proposals for recommendations, citing international comparisons with Denmark, but other countries as well, Japan. And I'm just wondering, does the WHO take a view on how countries should go about making recommendations? What factors should they take into consideration? And I think that's a question for Jeremy Farrar. Thank you.
Thank you very much, Catherine. Let's see, maybe on the EU pricing as such, we start with Dr. Etienne Krug, and then we see how we take the second one.
Yeah, thank you very much for the question. WHO has an excellent relationship with the EU indeed. We have many colleagues, and particularly an office called our Euro office that deals mainly with interactions with the EU. They're not here, so I cannot answer for sure if there has been in-depth discussions on the measures proposed by the EU, but I'm quite confident that there were interactions. But in the end, of course, it's the EU itself that sets its policies.
Dr. Farah, you wanted to add?
So just on the question of the U.S. policy changes on immunization, every country, as I think we've explained before, is responsible for their own policy formulation. And WHO provides recommendations on vaccines. What is really crucial as countries make their policy recommendations is that they use an evidence-based process that is systematic, it's transparent, and is really referencing the disease epidemiology of that particular country, the resources of the country, and it also includes assessments of equity and fairness and the feasibility of different vaccine programs. We've certainly seen the changes in the policy recommendations in the US, which, as I think we all know, now changes 6 vaccines into either into shared decision-making recommendations as opposed to universal recommendations for for children, or in some cases for pregnant women. And I think the important point of this is that shared decision-making is used in policy recommendations when the balance of the benefit and the risk is not clear to be able to make a universal recommendation, and it needs much more tailoring at the individual level. What is certainly clear from shared decision-making is that it requires a lot of consultation between a provider and a parent, and it certainly is an aspect that will further constrain in general the vaccine access that people have because of the time, the kind of discussions that need to happen. So the U.S. is making its recommendations and will be watching carefully about what the impact of those recommendations are on protection of children, especially from diseases for which we have safe and effective vaccines. And our WHO recommendations do provide that there are 14 diseases against which we have what we refer to as a global recommendation, which means that we do recommend that every country in the world is considering those vaccines for inclusion in their routine program. The U.S. has made a decision to step back from some of those vaccines and to revert them into a shared decision-making approach, which certainly can have, and we do have concerns, that this may limit the opportunity for children to benefit from these safe and highly effective vaccines.
Thank you. Dr. Farah, we wanted to go to Luz de Rigel before and then come back to you. Is that okay? Yeah. Luz, you wanted to add?
Thank you so much. I wanted to respond on the question related to food taxes. We have not received any request from EU, but probably our regional office in Europe has. So it's difficult to comment on that part. But what we can say is that we can see increased interest from countries in taxing food that is highly processed or ultra processing, depending on how you want to call it. We are working on an operational definition for this type of foods to facilitate the establishment of policies to limit the consumption. We are in direct contact with some countries in Europe, but also in other regions who are interested in limiting the consumption of highly processed foods. So we see a trend, and more questions are coming in that relation. Over to you.
Thank you, Luz, and now to Dr. Farah.
Yeah, there's just one thing to add to that. That is not only with the countries, but we're also working very closely with the International Agency for Research on Cancer in Lyon, the IARC. And this is an area, to Dr. Tedros' point earlier, of very clear common ground with the United States on the moves the United States is taking on highly processed food that came up during the younger discussions around non-communicable diseases back in September, and there is a lot of shared interest. Many countries, as Luz mentioned, but also with the US on how we set standards for ultra-processed foods, but also how we limit their use in future.
Thank you very much. And with this, we've come to the end of our briefing today. Thank you very much for joining us. We will send the audio files and the Dr. General's remarks shortly after this briefing. For anything else, please contact media inquiries at who.int. The mentioned and discussed reports are online now and can be checked there. And also for any further interview requests, please don't shy to contact us. And with this, back to Dr. Tedros.
Thank you, Christian. And thank you to all members of the press for joining us today. And see you next time.